Uh, we call upon Dr. Jacob Koshy, who is professor in the Department of Ophthalmology, Believers Church Medical College Hospital. He's a trainer to our PGs too. He'll be giving his two talks together, Intraop Small Pupil and PC Rent and Vitreous Prolapse. Over to you, sir.
Good morning, everyone. At the outset, I'd once again like to thank KSOS and Ashish for this opportunity. We've seen some fabulous surgeons now. You can see some problems that we make, and I'll just try and show how I would handle some of these. So first, I'll be dealing with intraoperative small pupil. Now, because we are talking about SICS, I'm not going to talk about the B-hex or any iris hooks and all, because those are difficult to use with SICS, especially as we are learning. And some of these small pupils may be intraoperative. Some of them you start with these small pupils, especially the bound down pupils in the uveitic cases. Always remember to, before you stretch it or do anything, please remember to just go under the pupillary margin and release all the synechiae. If you don't do that, the whole case becomes more difficult. So keep injecting viscoelastic, and it's not only at the pupillary margin, but you need to go all around. So you need to make 2 incisions and go all around. Once the synechiae is released, you can use these Y pushers, or you can use Kuglin hooks or whatever else you have in the theater. What I do is I make it at 3 different sites, and don't stretch it well beyond the limbus, like going very deep, because sometimes these can tear and cause massive bleeding in the eye. Just do a minimal stretch in 3 quadrants, and hopefully you're good to go. So this is another case that we see here, again a small pupil, and so I'm following the same technique that I said, where I first check to make sure that there is no synechiae. You put some viscoelastic. I've put a little bit of blue as well, and I go to stretch the pupil. So the 2 side ports should preferably be 180 degrees apart, so that you have better maneuverability. And I always make it in 3 different areas, and that gives me a fairly large size. And you can see here I'm doing an SICS case, and you can complete your rexus there. And most of the times these go pretty well. When you're prolapsing the nucleus, sometimes because of the stretch that you've created, the iris keeps coming in. Be careful when you're removing the nucleus. And again, during IA, you can easily catch the iris, you can catch capsules, so you need to be careful of what you're doing. Any lens can be put in if everything is going smoothly, whether you want to put in a PMMA or a foldable lens, and that should be fine. Now, here is another case where you have a small pupil, and you decide. So I try to put blue right in the beginning, because once you've put visco into the eye, then your staining is not very good. And I think that I should be able to manage it like the previous cases, where most of the time you do it pretty well. But sometimes when it rains, it pours, you start having problems, and then the problems keep compounding. And so here I think I'm okay. I think I'll start off with the rexus. Now, many of the times you have to do a blind rexus, where the tearing edge is just under the pupil. You can't see it clearly. And I think it's going well. And at somewhere around this stage, I realized that no, it has run off to the periphery. I'm trying to make some cuts to rescue it. Now iris has started coming out through the side port. I thought, okay, leave it. I'll just manage it. I thought I have a good tunnel, and you can see about 2 mm into clear cornea. But as soon as I start making the tunnel, some iris is sticking out, and I'm hoping it's just the floppy iris and nothing much. So I thought, okay, put some visco in just on top of the iris, push the iris down, and you should be good to go. So you inject visco there, and you should be good to continue. And suddenly the whole superior iris is coming out, and you realize you're in trouble. At this stage, I leave the iris alone. I don't manipulate too much. I'm going in with the vanas, and I'm hoping to make a nick to try and complete the rexus. So try and do these procedures without manipulating the iris too much. And so I managed to finish that. Now I've left with the difficult task of prolapsing the nucleus. Good hydrodissection is absolutely essential. And you can use the two-hook technique, which is now very popular, to get one port up and then rotate the nucleus into the anterior chamber. So till here it is fine. Now, all of you who've had iris prolapsing through a poorly constructed wound would know that this is the most difficult step where you can have hydrodialysis, and you have to be extremely careful watching the iris which is prolapsing through the wound, being very careful, and just maybe sometimes just get the big edge out and leave it there, and then be careful not to cause a superior hydrodialysis. That's just going to compound the problems even more. Thankfully, this was not a very hard lens, and I was able to get the lens out, and then you reposit the iris. You can do that with any iris repositor, and then gently start doing the IA. As soon as you start the IA, again you have iris prolapse, leave it alone, don't keep handling it, try and use the side port. And yeah, so here we have a PMMA lens going in. Thankfully, even though all the complications were coming, I did not have a vitreous prolapse or any rent or anything, and managed to put the lens into the bag. Remember to suture these wounds. You have to suture these wounds before you get out. Okay, so this is another patient now. Here there's a little bit of subluxation pre-existent with some vitreous. Make a small rhexis. We've already heard how to do that, and after you make a small rhexis, you want to just extend the wound. Here you already have a little bit of vitreous there, and inferior about 4 or 5 clock hours of subluxation, and I'm just trying to see if I can salvage it and put in a lens. Now, getting the nucleus out is the trickiest part. If you can manage without extending your subluxation, then you're good. Always keep checking to see if the other areas are okay and the extent of subluxation. Now here I decide to put in a PMMA lens into the bag without a CTR, using the haptics to stretch the area of subluxation. And the technique I use here is what I have learned is I put a second instrument under the optic, especially if you want to put it in the sulcus, so that it helps you guide it better. If whenever you're putting a secondary IOL in the sulcus, in this case I'm putting it in the bag, but put in some pylo, and make sure you've done an anterior vitrectomy. I've edited some of these things in the interest of time. Now here is another patient, fairly small pupil. So we think that we can manage these, and many of these things we are doing in a hurry because you might want to finish the list fast, and you do a blind rhexis, like I said, and things are going well. You prolapse one end out, start rotating. Sometimes getting this nucleus out of the PC into the AC itself is a challenge. You remember, use the two-hand technique. It makes things a little more easier. You can get the nucleus out, and everything is going well, and I start doing the IA through the side port, and many of these things are done blind, and then suddenly you pull out and you realize you've caught the capsule and you're pulling the capsule along, and then you just leave it there. Then your heart is in your mouth. You're wondering, have I pulled out too much? Should I have done that? Should I have not done that? Remember putting visco, trying to clear up, and you know that you have caused a zonular dialysis. Now this patient had a foldable IOL, which is, anyway, I just pushed it back into the capsular bag. There was no vitreous, and the dialysis was maybe 2-3 clock hours. It wasn't causing much problem. Centration was good, so I left it there. And then sometimes you have these cases which when you have the problem, you start wondering why you became a doctor, or why you took ophthalmology, or sometimes you start wondering why you were even born, those kind of things. And you're doing the case, and then half the nucleus has gone into the vitreous, and you have all kinds of things, and just trying to see what's happening there, and you see that the nucleus is floating in the mid-vitreous cavity, and you're desperate. Now, if the nucleus goes down, leave it, please send it to a VR surgeon. But here, I'm trying to handle it now. The block has worn off. Here, I'm planning to give a subtenon block to top up the block. Remember, if your block is not good, you cannot handle any of these things. Have a subtenon cannula, and it's a very easy procedure. Inframedially, just go under the tenons, go deep and inject, and that acts immediately. good anterior vitrectomy is mandatory in these cases, and fortunately the vitreous was a little gel, and I did a little bit of vitrectomy, cleared it up and could get it out. Triamcinolone is a must to make sure you're cleaning up adequately. For all the VR surgeons here, things may be very easy, but for us anterior segment surgeons, sometimes it's not. Once you've done a good vitrectomy, a dry aspiration, you keep putting viscoelastic and do a dry aspiration. Unless you're very sure, don't have fluid flowing into the eye, it will just go and hydrate the vitreous and more vitreous will pop out. But you can do a dry aspiration, keep it in retroillumination and try and see what's going on. At this point of time, I'm feeling a little more confident that I should be able to manage it as things are getting better. I keep removing the viscoelastic. Again, I put a little bit of tricot because I want to make sure whether I have brought out any more vitreous. Do a good anterior vitrectomy. Sometimes this tricot might go a little back, and on retro it will look a little white, and you might start wondering, oh, have I caused a detachment or anything, but generally they are okay. Remember to keep sweeping on top, and you can see a little bit of vitreous tag there, things like that, so that you know what to remove. Now, once you have done an adequate vitrectomy and you've cleaned up adequately, now here you're definitely planning to put the lens in the sulcus. Remember to inject the viscoelastic under the iris and above the anterior capsule. And again, just check all around if there is adequate support. Obviously, a PMMA lens would be better here, or a 3-piece lens. Don't put a single-piece foldable lens. And again, put it, be careful to go just under the iris, above the anterior capsule, injecting viscoelastic, and then you can dial it or push it in on whatever technique you're more comfortable with. Yeah, and you find that the lens is pretty stable there because there was good anterior capsular support. And remove. So these patients will have some visco coming back for the next few days, and so the pressures will be a little high. How much ever you clean in the anterior chamber, the pressures will remain high. Remember to manage the pressures well for the first few days. You can put in a bit of pilocarp in there if you want to make sure that to get the pupil down, as well as to make sure that you don't have any vitreous in the anterior chamber. Cleaning it up. Any patient you've done a vitrectomy, please remember to put in a suture. The last thing you want after all this is to try and go back because you have a leaky wound or a soft eye the first post-op day. So generally what I would do is I put a single cross suture for these cases. You can put a Fine's infinity suture if you know how to do that or you're comfortable with that. I usually put this cross suture. It hardly causes any astigmatism. It's just one single cross suture across the breadth of the wound. And you make sure that your wound is absolutely watertight. One thing that you will notice is the air bubble is pretty stable and it's not leaking out. That itself is a good sign that you know that the anterior chamber is good. The IOL is in position. Everything is fine, and yeah, you can close the case. And so you started off thinking, why was I born? Then you're thankful that you managed to finish the case by God's grace. And yeah, that's how I would try and manage an anterior case where the posterior capsule is ruptured with vitreous loss. Sometimes it's not always this smooth, and remember that if you can't manage it, just ask for help. That is more important than trying to be a hero in these situations. Thank you so much for your patient listening.
Really fantastic videos, and we all get into this kind of problems, and you managed it so very well. And thank you for being very frank with us, and because all of us feel that way in some stage or the other.